Okay, so in this video, Chapter 8, we're going to talk about disorders of fluid, electrolyte, and acid-base balance. So when we talk about fluid distribution all around the body, uh, most of our body's fluid is actually found intracellularly, so it's actually within your cells. So of the 100 trillion cells in your body or so, those have 2/3 of your body's water within themselves. So the cytoplasm has a lot of water in there, right? Spread out amongst 100 trillion cells. Now, the remaining 1/3 of your body's fluids are extracellular. So when you start talking about like tissue fluid or interstitial fluid, which is the fluid you find within tissues, we also have blood plasma, which is actually the watery component of blood. We found this in the vascular compartment, or basically your blood vessels. And then we also have something called the transcellular compartment. Now, the transcellular compartment would be those epithelial line spaces around your body. So, and an example of that would be like your synovial cavities, which have synovial fluid. That would be considered, like transcellular fluid within that compartment. So, if we look at this picture here, we're basically looking at just a general image of tissue somewhere in the body, right? We can see some blood vessels going through it. You have some connective tissue outside of that, and then some cells that are embedded within that connective tissue. So remember, 2/3 of your body's water is actually intracellular, right? So it's actually found within the cells itself. The remaining third is going to be in places like interstitial fluid, which is the tissue fluid, also fluid in your blood, which is called plasma, as well as the transcellular compartment, which would be in epithelial line spaces like synovial membrane. So when you look at these different fluids of the body, they don't all have the same composition. So we think about where water is located, but it's not just pure water inside your cells or in the tissue or in your plasma. There are ions that are dissolved in those fluids as well. So in a little bit, we'll get to some of the different electrolytes and electrolyte imbalances. But what's important to note, though, is that intracellular fluid has the highest concentration of potassium, and extracellular fluid is going to be higher in sodium. And the reason for this is that your sodium-potassium pumps of your cells pump potassium in and sodium out. So it actually establishes a particular gradient, between the intracellular and extracellular fluid compartments. So this first scenario here we see is an athlete ran a marathon even though he felt ill, and after the race he collapsed. He was pale with low blood pressure, sunken eyes, one knee and ankle were badly swollen, and his abdomen was distended with fluid. The doctor diagnosed appendicitis and dehydration. So the question here says, what has happened to his blood osmolarity, cell size, transcellular compartment volume, and vascular compartment volume? Well, remember with blood osmolarity, we're talking about osmolarity is a measure of the number of dissolved solutes or concentration of dissolved solutes in a particular volume of fluid. So if you're dehydrated and you've lost water, you're essentially concentrating that fluid and you're concentrating the solutes because you're removing the water from that solution. And so in the case of this athlete who ran a marathon, because they're dehydrated, they should have a higher blood osmolarity, right? Like the osmolarity of their blood is going to be slightly higher than 290 milliosmoles. It might even be closer to 300 or over 300. Now, if your blood osmolarity is higher, that means it's saltier, right? And so we got to think about, well, what happens to the size of your cells and your tissues? Well, we know that water follows solutes, and that's sort of the concept behind osmolarity, or not osmolarity, osmosis. So with cell size, what happens then is that if your blood becomes more salty or has a higher osmolarity, it's going to eventually pull water out of your body's cells. So you're actually going to remove water from the intracellular fluid compartment that's going to be brought into the extracellular fluid compartment. So the cells of his body as well actually would have shrunken a little bit just because of this increase in osmolarity. Now this transcellular compartment volume, if you remember, transcellular compartment is like the epithelial line spaces, like your synovial membrane. So in the case of this athlete, his knee and ankle were swollen. So the swelling that's occurring in that joint would be due to an increase in the amount of fluid within this particular compartment. So the transcellular compartment volume would increase. And then what about the vascular volume? Well, with dehydration, if you're losing water from your blood, through sweat or excessive urination or just decreased intake, what we find here then is that the vascular compartment volume would likely be less or lower, and this would explain also the low blood pressure and sunken eyes. Um, and so there's just some things to consider in this particular scenario. So just as a summary or review of osmosis, we talked about how water follows solutes. So if you remember in the last example, one example we gave was, if someone's blood osmolarity increased, how you can pull water out of the intracellular fluid environment. Like, let's say if you have more solutes on one side of a semipermeable membrane versus another, well, the water is going to go to the other side. Now, this actually generates a pressure, right? Because this membrane is only permeable to water, not these solutes, so that water has a tendency to be on this side until the concentrations of these two sides are actually equal. And so if you look at the column of water on either side, this side's higher, and this actually generates a little bit of a pressure because of this water movement, and we call this osmotic pressure. So there's two major osmotic pressures we'll talk about with respect to blood and blood flow. And that's the osmotic pressure inside your capillaries and osmotic pressure inside of your interstitial fluid. So osmotic pressure inside the capillaries is actually mediated by a protein called albumin. So imagine if all these little blue circles were albumin. Effectively, what albumin can do is pull water from tissues back into blood. That way you don't lose all of your blood water, or plasma into your tissues. Another example too is, let's say these are solutes within your tissue. You can also pull water out of blood or out of cells into the tissue itself. So that's important to note with respect to, solute concentration. So this question here says, what forces will work to keep blood in the capillary? And this is going back to a review from ANP2, where we talked about how we have the hydrostatic pressures and the osmotic pressures. If y'all remember, hydrostatic pressure was just fluid pressure. An example of that in the blood was blood pressure. So your blood's pressure is a hydrostatic pressure because blood pressure is compressed liquid, and it's a tendency then to expand and force on the walls that contain it. So that, if you think about blood pressure forcing up along the walls inside of a blood vessel, that's not going to keep blood in the capillary. In fact, that's going to have a tendency to force water out of the blood into the tissue. So we don't want to talk about then capillary hydrostatic pressure, because that's actually going to force water out. What we want to look at then will be things like tissue hydrostatic pressure, which is going to force fluid into the bloodstream through the capillaries, or osmotic pressures. So going back to the last slide, we talked about how if this were your blood and these little solutes were albumin, the albumin in your bloodstream can actually pull water into the bloodstream. And the albumin solutes in your bloodstream actually mediate something called osmotic pressure of the capillary, which helps to bring water back in. So going back to this question here, it says which forces work to keep blood in the capillary. The best answer here would be D, which is capillary colloid osmotic pressure and tissue hydrostatic pressure, because both of these pressures would have a tendency then to bring water back into the bloodstream. Because with capillary colloid osmotic pressure, you're actually drawing water from the tissue into the bloodstream via osmosis, and with tissue hydrostatic pressure, you're actually forcing water back into the bloodstream because of tissue pressure. So an example of things that could cause an increase in tissue hydrostatic pressure would be like compression socks, where if someone has edema in their legs, they can wear tight socks that increase the tissue hydrostatic pressure, and it forces that excess fluid back into their bloodstream. So again, the best answer here is D. So the rationale here is the hydrostatic pressures can be thought of as a pushing pressure. So remember, hydrostatic pressures are blood pressure or just fluid pressure. It's going to force fluid in a particular direction. So if it's hydrostatic pressure of the interstitial fluid, it's going to push water back into the bloodstream. And osmotic pressures are a pulling pressure. So if it's a pulling pressure that's within your blood, like with capillary colloid osmotic pressure, then it's going to pull water into your bloodstream. So the first electrolyte we'll talk about in terms of electrolyte imbalances is sodium. Sodium is the first and foremost most important one to discuss because for one, it's the most abundant electrolyte in your extracellular fluid, and it actually mediates the strongest osmotic driving force of all of the electrolytes. So when you start talking about sodium balance around the body, that also is going to explain where water is moving. So normal levels of sodium in your body would be 135 to 145 milliequivalents per liter, and it helps regulate extracellular fluid volume because it has a strong osmotic force. So this question here says, why would retaining sodium cause high blood pressure? Well, knowing that sodium draws water, or sort of, attracts water, what we can say here then is that if you have a lot of sodium in your bloodstream, that's going to help you retain water because sodium attracts that water. Now, we do understand that there's a relationship of blood volume to blood pressure. So if you have a higher blood volume because you're retaining water because your sodium levels are high, that also is going to correlate with higher blood pressure. And so we say that high salt diets, which cause you to retain sodium, could also lead to higher blood pressure because you're also retaining water with that sodium. So the scenario here says it's a very hot day and you fall down the stairs on the way to see the doctor about your hepatitis and renal disease. Woo. So this question says, explain why you have edema in your sprained ankle and foot, right? So the scenario kind of gives the answer away a little bit. Let's just assume that the fall wasn't the thing that caused the swelling in the ankle and the foot, right? Let's just assume here that it might be something like a hepatitis and renal disease. So the question then is, what's the relationship of hepatitis to edema, and what's the relationship of renal disease to edema? Well, remember, hepatitis is liver inflammation, and typically with that you see a decrease in liver function. Now, earlier we talked about how albumin was a plasma protein that helps to mediate colloid osmotic pressure of the capillary. Now, that also draws fluid from your tissue into your bloodstream, right? Now, if you have hepatitis and you're not making albumin, because albumin was made by the liver, that means your serum albumin levels could be low. We call that hypoalbuminemia. And that if your serum albumin levels are low, then your capillary colloid osmotic pressure is low, which means that you're not able to draw water into the bloodstream as easily, and instead the capillary hydrostatic pressure is going to take over. It's going to force that water into the tissue rather than being drawn back in to the bloodstream. So that can promote edema or swelling. And the reason you might see this in feet or ankles is that they're closer to the ground. They're under kind of a greater influence of gravity because they're farther from your heart. Now, what's the relationship of renal disease to edema here? Well, we know that your kidneys help get rid of excess water and electrolytes. So if because of your kidney disease, you're not able to remove that excess water, that means your blood pressure is going to be higher, and there's going to be a general tendency for your hydrostatic pressure of your capillary, aka blood pressure, to force water into your tissues, which could explain the edema here. Now, another side of this too is you could just say that the fall in and of itself caused the swelling in the ankles and the feet, depending on how they fell on the stairs, right? We don't know for certain from the scenario if it's the fall that caused the swelling or if it's the hepatitis and renal disease. But we already talked about the relationship of inflammation due to damage and the swelling or edema you see with that. So if sodium is so important, how do you control the osmolarity of that in your bloodstream? Well, what we find then is that if your blood osmolarity is high, which would suggest that your water levels are low or your sodium levels are high, this also causes you to become thirsty. And so this is mediated by a portion of your hypothalamus called the area postrema that actually measures blood levels of circulating ions and chemicals and that kind of stuff. So that if your osmolarity is high, you get thirsty because your hypothalamus can sense that high osmolarity using osmoreceptors, and this thirst causes you to seek out water. So when you drink more water, it dilutes the ions so that your osmolarity then goes down. The other side of this too is that high osmolarity causes you to release antidiuretic hormone from your posterior pituitary. Now the posterior pituitary releases ADH, and ADH has its target tissue in the nephrons of your kidneys. So what happens when ADH is being released in high quantities is that you actually reabsorb more water from your nephron. You don't lose it into urine, so that you actually retain that water, and so that you don't continue to lose water, so that could also reverse this high osmolarity and decrease it by essentially diluting it down. Now, the opposite of this would be like low osmolarity, right? So if you have low osmolarity, which could be from excessive water in the blood or potentially low sodium levels in your blood, essentially low osmolarity causes lack of thirst, right? You just don't feel thirsty. And this also decreases the release of ADH, so that if your osmolarity is low, you don't release antidiuretic hormone from your posterior pituitary. And instead, because you're not reabsorbing water, you lose more water into urine. So it's going to increase urine output, which would increase water loss. So this question here says true or false. Increased levels of ADH decrease urine output. And the answer to that is true, absolutely, right? Like if ADH prevents diuresis, it's in the name, antidiuretic hormone, and you increase levels of ADH, then you're going to decrease urine output because you're reabsorbing that water and you have a smaller volume of urine being formed. So what we see here is another case study or scenario where we say that dehydration could also be due to hypodipsia, right? So hypo means below, dipsia means thirst or drinking, right? So hypodipsia, which would be sort of not drinking enough water, is a common problem in elderly because their osmoreceptors don't work as well, so they're less likely to feel thirsty. And it can also be due to the fact that they don't move as easily. Like if it's difficult for you to move around and go get a glass of water, that's also going to limit how much water intake you can potentially do or undergo. So the scenario here says, well, imagine if you have an elderly patient. One doctor, Dr. Bob, thinks it could be treated with an ADH nasal spray. Another doctor, Dr. Bill, thinks renin injections would be better. And so this question here says, what's your evaluation of these two options? So, well, which one will be better for somebody who's not drinking enough water is the question here. So ADH versus renin, right? Now, renin, if you all remember, is a hormone that's released by your kidneys when your blood pressure is low, or if the osmolarity of the filtrate at the end of the nephron is low. And the relationship here is that if your blood pressure is low, your glomerular filtration rate is also slow or low. And if filtrate moves to the nephron more slowly, you have more time to reabsorb electrolytes from that fluid, so that the filtrate osmolarity is also going to be low by the time the filtrate gets to the end of the nephron. So that both of these actually lead to the release of renin by cells of your juxtaglomerular apparatus. And so renin is a hormone/enzyme that, released by your kidneys, enters the bloodstream and converts angiotensinogen into angiotensin 1. Then angiotensin 1 is converted to angiotensin 2 by ACE, or angiotensin converting enzyme, which you find in structures like your lungs, your brain, your kidneys, and your liver. Now, the major effect of angiotensin 2 is, for one, it actually causes the release of ADH by the posterior pituitary. It also causes your hypothalamus to increase sort of the sensation of thirst. Angiotensin 2 in and of itself is also a potent vasoconstrictor, and angiotensin 2 stimulates the release of aldosterone by your adrenal cortex, which causes your kidneys to retain more sodium. So this renin injection would lead to a lot of different effects, all of which would act to increase blood pressure, right? Now, the problem here isn't necessarily low blood pressure. It's just that they have low water intake. So, ADH is an aspect of this whole renin cascade. But antidiuretic hormone, all it does is it actually acts on the kidneys to help you reabsorb water, so it decreases urine output. So between the two options, renin is going to be stronger because it affects multiple pathways. ADH is going to be a little weaker because it's only one mechanism of water reabsorption, right? And because this pathway here, or ADH mechanism, directly acts on the water loss, what happens then is that this would be the better option of the two because you're just going to retain more water. Whereas renin, you're going to get the release of additional hormones that cause you to retain excess sodium and also increase blood pressure. So there's more potential complications with this renin injection. And you have to inject somebody, right? So that's going to put them at a higher risk for infection. Whereas a nasal spray, you just absorb across the nasal mucosa. So with antidiuretic hormone, this is released by the posterior pituitary of your in your brain there, and it acts on the collecting ducts of your nephrons in your kidneys. Now, in terms of ADH imbalances or disorders, we have a couple here. One's called diabetes insipidus. Okay, so diabetes literally translates to siphon in Greek or Latin. I forget which one of those two. But essentially what that means is water loss, right? So when you see the word diabetes, think water loss. And then insipidus because it's just excessive. So diabetes insipidus is due to either an insufficient release of ADH, which we call neurogenic diabetes insipidus, or if your kidneys don't respond appropriately to ADH, then we call it nephrogenic diabetes insipidus. So there's two major causes of diabetes insipidus here. But in both cases, you're going to get excessive water loss. Because in this disorder, you're either not releasing ADH when it's appropriate to release it because of brain injury or some other problem, or your kidneys are no longer sensitive to ADH, or they're not responding appropriately to ADH. And so that the problem isn't that you don't have low hormone, the problem is that your kidneys aren't responding appropriately. So in that regard, we call it nephrogenic diabetes insipidus. But in both conditions, you get excessive water loss because in the absence of ADH, you have a higher urine output. Now, opposite to this is one called syndrome of inappropriate antidiuretic hormone, or SIADH. And the syndrome of inappropriate ADH is essentially a condition where you're releasing antidiuretic hormone even when your blood osmolarity is low and your blood sodium levels are low. So that this is going to exacerbate the problem by retaining more water. You're going to have higher blood volume, lower osmolarity, higher blood pressure, right? So this can lead to skyrocketing blood pressure. This question here says, which will cause hyponatremia? Well, one thing that's important to note is that if you lose a lot of water and you're losing that water really rapidly, you're often going to lose sodium with that, right? So this question says, which will cause hyponatremia? Either of these can lead to hyponatremia, but the hyponatremia that's going to be worse would be with diabetes insipidus here, because the excessive water loss, you're going to really lose that sodium from your body really quickly with it. And so hyponatremia is just low blood sodium, and that's going to go with the water, if that makes sense. So in terms of sodium imbalances in the body, we talk about hyponatremia and hypernatremia. Hyponatremia is where you have sodium levels that are below 135 milliequivalents per liter. And that's where it could be due to dilutional, right, where you actually have low sodium levels because they're diluted out with water. And then hypernatremia would be when you have sodium levels that are above 145 milliequivalents per liter in your blood. And this could be due to a water deficit, where like if your blood plasma levels are low, then you have a higher concentration of sodium because of the water loss. This could also come from sodium administration. Like if you give someone hypertonic saline, that can lead to hypernatremia. Or if someone just has high sodium intake, that can also lead to hypernatremia. Now the scenario here says a man with hypernatremia was severely confused. This question says the doctor said he was due to a change in the size of his brain cells. And why would this happen? So let's think about this. Hypernatremia is high blood sodium. That means that their blood plasma is hypertonic. And if you all remember, going back to tonicity, we said that cells exposed to a hypertonic solution, they shrivel because the water leaves the intracellular fluid compartment and then goes into the extracellular fluid compartment. And so due to this change in the size of the brain cells, this can lead to confusion because they're not able to function correctly because of the tissues deformed. So this would happen because of the hypertonicity of the blood plasma. And then a medical student suggested giving him a hypotonic IV. So why don't you just reverse the problem and give them a hypotonic IV? And this says why. And the rationale here would be, well, if you can dilute the sodium that's already in their blood with a hypotonic solution, that could help reverse the issue here. And the doctor said this might worsen the change in his brain size, so his blood osmolarity should be corrected very slowly. And the answer here is, the question here says, why is that? Well, if you give someone a hypotonic IV, not only are you diluting out the sodium a little bit, but you're also increasing their blood pressure. And by increasing their blood pressure by basically delivering more fluid, that can actually force water into the tissue even more quickly, and that can cause swelling within the brain, which you want to avoid already because there's already trauma to the brain itself. So you want to correct this problem more slowly over time. That way the cells can kind of naturally reestablish, their normal electrolyte and water balance. So let's talk about potassium here. With potassium, it is a cation that you find normally in high concentration within your body cells due to the activities of your sodium-potassium pump. And if you look here, blood levels of potassium are really low compared to sodium. Like we only have 3.5 to 5.0 milliequivalents per liter of potassium in your blood plasma. So its major function is to maintain intracellular osmolarity, and it also controls the resting membrane potential of most of your body's cells. So when you start talking about changing potassium levels in your inside your cells or outside your cells, it's also going to change the voltage across the membrane of those cells, which is particularly important for muscle cells and nerve cells. So it's something that's used by the sodium potassium pump, and potassium levels are also exchanged for hydrogen ions to buffer changes in blood pH, right? So that if you start moving hydrogen ions out of blood and you want to maintain charge balance, well, potassium is typically exchanged for this cation. That way you keep the same charge balance there in the blood. So when we talk about changing potassium levels in the blood, when you use phrases like hyperkalemia and hypokalemia. Well, hyperkalemia means high blood potassium. Hypokalemia means low blood potassium. And so what this picture here is showing is the resting voltage of 3 different cells. And this is showing let's just say these are neurons. And this is showing the threshold potential for action potentials in those neurons, right? So let's say that under normal conditions, you're probably about 15 millivolts or so, or 15 to 20 millivolts away from threshold of action potentials, normally. But let's say if you have a cell that's exposed to a hyperkalemic state, so that the blood or tissue fluid became hyperkalemic temporarily, you'd find that, first of all, the resting voltage would increase to a higher voltage level, right? Which actually gets you closer to action potential threshold. And what this means then is that individuals with hyperkalemia, it's actually easier to get to action potential threshold, so you get an action potential even sooner. Now that's a problem with your nerve cells because they might fire uncontrollably or inappropriately because they're too close to the threshold. It's also a problem with your muscle cells because this can lead to overactivity of muscle. Now the opposite is true of hypokalemia. Like if you have low blood potassium, what happens here is that your resting membrane potential becomes more negative, and this actually makes you farther from action potential threshold. So in the condition of hypokalemia, it's actually more difficult to get to action potential threshold to get an action potential. So what you'd find in hypokalemia would be a decrease in neuromuscular excitability. And so that's opposite of hyperkalemia, where you saw an increase in excitability because you're closer to threshold. So with hypokalemia, you'd see that nerves would fire less frequently or more slowly. Your muscles would contract less frequently and more weakly, right? And so that's going to be particularly prominent on your heart muscle, which is required to pump blood and maintain blood pressure. So if you have hypokalemia, you can see low cardiac output and low blood pressure as a result. So this question here says, what will happen to blood potassium levels when a client has the following? So let's talk about hyperaldosteronism first. If y'all remember, aldosterone is a hormone that's released by the zona glomerulosa of your adrenal cortex, and it's stimulated by angiotensin 2, which comes from renin. So that the effect of aldosterone is actually on the nephrons of your kidneys, and the receptors for aldosterone are on the distal convoluted tubule. So if someone has hyperaldosteronism, what happens here is that aldosterone causes the kidneys to retain sodium and secrete potassium. So the effect of aldosterone is always to reabsorb one sodium from the filtrate and simultaneously secrete one potassium. So what would happen to blood potassium levels over time if you had hyperaldosteronism is that you actually would have hypokalemia, right? So you'd have low blood potassium because over time you'd be retaining way more sodium but then secreting a lot of potassium. And so hyperaldosteronism then could lead to high blood pressure because you're retaining sodium and therefore water, but it would also lead to hypokalemia if severe enough, which could lead to a decrease in neuromuscular excitability. So you're going to see things like weakening of muscle, slowing of heart rate, and heart muscle contraction, which would decrease cardiac output, right? So this one here says, what about alkalosis? Well, if you remember, we talked about how potassium and hydrogen are usually exchanged with each other to maintain charge balance. So if you have alkalosis, which would effectively be, a high blood pH, which means it's more alkaline or more basic, To make that more acidic, to get back to a normal level, you want to reabsorb hydrogen ions. But the same thing occurs here where you're exchanging a hydrogen ion for a potassium ion. So alkalosis would also lead to hypokalemia, where you're actually losing potassium by retaining more hydrogen ion. And another question here says, what about an injection of epinephrine, right? Well, epinephrine is essentially a sympathetic hormone that is involved with the fight or flight response. Now, if you're injecting someone with epinephrine, what happens then is that their muscle cells can become more active, especially like on their heart, and because of the increase in activity of these muscle cells and the increase in activity of action potentials in those cells, you see that there's a larger efflux of intracellular potassium from those cells. So with an injection of epinephrine, you'd find that blood potassium levels could temporarily rise because potassium is now leaking from the intracellular fluid into the extracellular fluid from an increase in the number of action potentials. And then what about during convulsions? And there would be a very similar effect too to epinephrine because convulsion is overactivity, which again would lead to higher levels of potassium in the blood. Now, loop diuretics. Now, a loop diuretic is a type of drug that acts on the nephron loop, and it prevents the reabsorption of sodium, potassium, and chloride. So if you don't reabsorb those electrolytes, then it's more difficult to reabsorb water because water is only reabsorbed through osmosis. So a loop diuretic would prevent you from reabsorbing potassium, so you actually would lose more potassium into your urine. So over time, a loop diuretic would actually decrease blood potassium levels and could lead to also hypokalemia. So this question here says, what effect does a potassium level of 7.5 milliequivalents per liter have on resting membrane potential? Well, if you remember going back to the normal values, we said that normally it was between 3 and 5 or so milliequivalents per liter. And so if it's above that, then we're saying that this would actually be considered hyperkalemia. And if you guys remember, hyperkalemia makes your resting membrane potential more positive, so it's closer to action potential threshold. And so the answer here is that resting membrane potential becomes less negative or more positive, which means it takes less of a stimulus to get cells to fire. So they're going to be overly active. And so in the case of hyperkalemia, you see an increase in neuromuscular excitability. So with calcium as another electrolyte, we want to talk about how it's regulated first. And we know that calcium regulation begins with the parathyroid glands. So the parathyroid glands receive blood flow, and they're behind your thyroid, but they receive blood flow, and they have chemoreceptors that measure blood calcium levels. So if your serum calcium levels are too low, what happens is your parathyroid glands release parathyroid hormone, or PTH. Now what parathyroid hormone does is it does three major things. Is for one, parathyroid hormone causes the osteoclasts of your bone to break down the bony matrix via resorption, so that actually releases some of the calcium from the hydroxyapatite minerals in your bone. So that's going to increase blood calcium. But this is through bone breakdown, right? Now, parathyroid hormone also acts on your kidneys to increase reabsorption of calcium. That way you don't lose calcium into your urine. And it also promotes the formation of vitamin D by your kidneys. So that vitamin D as a hormone released by your kidneys actually causes your small intestine to also reabsorb more calcium, which over time would increase your blood calcium levels. Now, over time, and once these are actually at a normal level, the presence of normal calcium levels would actually prevent your parathyroid glands from releasing any more parathyroid hormone. That's why it's negative feedback here. So it's going to shut the whole process off. Now, one thing that's kind of important to note about this process is that most of the calcium in this example comes from the bones. So if you're relying heavily on parathyroid hormone to keep your blood calcium levels high, effectively what you're doing is promoting bone resorption or breakdown. And over time, that can lead to osteoporosis and brittling of your bones. So why do we want to maintain normal calcium levels in the body? Well, for one, we got to maintain them extracellularly at between 8.5 and 10.5 milligrams per deciliter. And so they're important to maintain normal levels in the body because they're involved with bone strength and stability. Calcium levels are also important for membrane potentials, like the voltage of your cells, as well as membrane excitability, because calcium is involved with like exocytosis of vesicles and neurotransmitter. Calcium is involved with contraction of all three muscle types, because remember, calcium was one of the key steps in the sarcomere contraction phase. Calcium is also important in clotting. In fact, you can't clot properly in the absence of calcium. So that's really important there. And calcium is a second messenger in many hormonal and intracellular signaling cascades. So that if calcium levels aren't normal inside of your cells, then their cells don't communicate properly intracellularly. So this scenario here says a man with metastatic cancer complains of bone pain and sudden weakness. And so the questions we have here are, why did the doctor measure parathyroid hormone or calcium levels in vitamin D? Well, going back to our cancer chapter, we talked about how some malignancies, you can actually get paraneoplastic syndromes, where effectively these cancer cells can release hormones that they wouldn't normally release. And one of those hormones we discussed was a parathyroid hormone-like protein. And so what can happen is there's sometimes these cells can release, parathyroid hormone, and so that's why you would want to measure that. And you can see, well, is the weakness due to high serum calcium? And the reason being here is that if you have hypercalcemia, it actually causes a decrease in neuromuscular excitability by making your resting membrane potentials more negative. And that would explain the weakness here. So first of all, you want to look at, okay, what are his parathyroid hormone levels? Are they high or low? Well, with the metastatic cancer, they could be high if it's a paraneoplastic syndrome. Now, with a sudden weakness, that could be caused by high serum calcium, because remember, hypercalcemia leads to a decrease in neuromuscular excitability. And you could also want to look at vitamin D levels too, because if this individual has vitamin D that's in excess, then they could be reabsorbing too much calcium from their gut, which could also cause the hypercalcemia that we suspect would be associated with the weakness here. Now, in terms of controlling nerve firing, we just said that hypercalcemia decreases neuromuscular excitability, and the opposite would be true of hypocalcemia, right? So if you have low serum calcium, the nerves fire more easily. So, essentially what we're seeing here then is that, if you have muscle cramps, that could be due to low serum calcium. You might want to increase calcium intake in some regard. Or if you have muscle weakness, it could be from hypercalcemia. And so this question here says, which would cause Trousseau's sign? Now, Trousseau's sign is an effect where if you put a blood pressure cuff on a patient, after about a minute or so, their hand can cramp up. And this happens in about 1% of individuals. And it's actually a way to diagnose calcium dysfunction just by basically, restricting blood flow to the muscles of the forearm. And so Trousseau's sign, which is leading to muscle cramps, would be caused by hypocalcemia. So hypocalcemia is something that can lead to Trousseau's sign. And so if you put a blood pressure cuff on a patient and their arm starts cramping up, that might be due to the fact that they have hypocalcemia or not. You don't need to measure that additionally, because there's some contraindications too. But Trousseau's sign could be because of hypocalcemia. So this question here says, true or false, both hyperkalemia and hypercalcemia cause cells to fire more easily. So let's think about this. Hypercalcemia decreases neuromuscular excitability. So that's not true, that's for sure. But hyperkalemia does increase neuromuscular excitability. So that's definitely false, right? So although hyperkalemia does cause cells to fire more easily because you're getting closer to action potential threshold, your resting voltage is closer, that one's true. But hypercalcemia causes the opposite. Hypercalcemia actually makes your resting membrane potential more negative, and so it actually makes it more difficult to achieve an action potential, so that you're less likely to see action potentials firing. So that would be opposite, and therefore false. So talking about phosphorus as an electrolyte in the body, we say that normal levels of phosphorus in the bloodstream are about 2.5 to 4.5 milligrams per deciliter. Now we know that phosphorus is involved with bone and ATP formation, because remember we said that calcium phosphate minerals are the hydroxyapatite of bone. And ATP, phosphate is also important in ATP, right? It's adenosine triphosphate. Now, it's involved therefore with also glucose, fat, and protein metabolism. It's a component of DNA, RNA, and phospholipids. It plays a role in acid-base buffering, and it also plays a role in red blood cell, white blood cell, and platelet function. So you can imagine then if your phosphate levels are too low, you'd see a dysfunction in all of these sort of essential mechanisms of your body. So magnesium is also an electrolyte that you find within concentrations of 1.3 to 2.1 milligrams per deciliter. Now, magnesium is significant because it's a cofactor in a lot of enzymes. So remember, cofactors and enzymes are a necessary component to enzymatic reactions, so that magnesium stabilizes ATP. So in fact, magnesium you always find with ATP, and it keeps it stable and it prevents it from just degenerating spontaneously. Magnesium is also involved with DNA replication because it's a cofactor in things like helicase, which unzip or unwind the DNA double helix. It's also involved with mRNA production and translation. So you can imagine then magnesium is involved with a lot of very important reactions. Now, what's also interesting too is that magnesium blocks potassium exit from cardiac muscle cells. So remember, potassium exit is what causes the repolarization phase of muscle. So if you have hypermagnesemia, it's going to take longer for this muscle to relax because you're blocking the exiting of potassium. And so you're going to see that these longer muscle contractions in cardiac muscles. Now, in smooth muscle, it functions as a relaxant. Now, what we're going to do next is talk about acids and bases in the body and how they're controlled and regulated. So what's interesting here is there's actually a correlation between acidity of your blood and respiratory rate. Now, when you think of acids, you think of H+, which is a proton, and this H+ has a lot of different sort of sources in the body, but ultimately the concentration of hydrogen ions in your bloodstream helps determine how fast you're breathing. Now, you're not able to breathe out hydrogen ions directly, but it does play a role with this particular acid right here, which is called carbonic acid, which is H2CO3. Now, H2CO3 is a type of acid that is formed by the convergence of CO2 and water. So when you add CO2 plus H2O, you end up with H2CO3, and it's actually how carbon dioxide is transported around your bloodstream. So what this means then is that when carbon dioxide is dissolved in blood, you're actually acidifying the blood. Now, because you can breathe out the carbon dioxide, you're kind of indirectly removing carbonic acid, and that's why the respiratory rate plays a role there. Now, there's other non-volatile acids as well. Non-volatile acids are not able to be breathed out, like CO2 can. And so other sources of non-volatile acids would be things like from energy metabolism, like lactic acid, from digestion, like hydrochloric acid, or the keto acids that are produced if you're relying heavily on fat metabolism. So if you think about like blood pH, and its normal levels would be between 7.35 and 7.45, you got to keep within that pretty narrow range of pH. So we know that there's different sources of acid in your body. With food intake, you have digestion, absorption, and metabolism, which can lead to the production of acids directly from metabolism, or carbon dioxide can lead to acid because it can turn into carbonic acid. But you can also get sulfates, phosphates, and chlorides that are produced from metabolism. So ultimately, the metabolism of our body leads to the formation of acids, and we got to get these out of our body to prevent the acidification of our body's fluids. So how do we do this? Well, there's actually 3 lines of defense. We have chemical buffers, the respiratory response, and your renal response. So the first line of defense here in the buffer systems is chemical buffering. So what a buffer means is it's a chemical that's able to prevent wild fluctuations in pH under changing concentrations of acid or base. So what happens here is, let's say that you do have acid accumulating, like hydrogen ions accumulating here. Chemical buffers could actually prevent this hydrogen ion from leading to a big change in your blood's pH. An example of a really important buffer in your blood is bicarbonate ion, which is HC3O-. Now, the second line of defense is actually your respiratory response. Because you're able to breathe out volatile acids like carbon dioxide, your lungs can help breathe out CO2 and effectively remove carbon dioxide from the body and thereby prevent the formation of carbonic acid. So by breathing heavily and breathing out CO2, you can indirectly remove carbonic acid from the body. And this is a little quicker than the third line of defense, which is the renal response. The renal response is the slowest of these 3 because it takes extra time to get rid of acids or bases in your urine. But when you talk about the sulfates, the phosphates, and the chlorides, these are always lost through urine, so they're excreted through urine. And the renal response could also do things like, help you to excrete excess hydrogen ion or excrete excess bicarbonate ion, depending on, if your blood's acidic or basic. So in terms of pH of your blood, normal value is 7.35 to 7.45. We know that's regulated by chemical buffer systems as well as your lungs. So that's the first line of defense, is the buffers inside of your cells and your bloodstream. And then your lungs help eliminate carbon dioxide, which is a volatile acid. So if it's volatile, it means that it can go into a gaseous state. This is why you're able to eliminate it, because CO2 is a gas. Now, by eliminating CO2, you're also eliminating carbonic acid, because CO2 in water makes carbonic acid. Now, your kidneys are the third line of defense here, and they eliminate hydrogen ion directly, because you can actually use these proton pumps, or I'm sorry, the hydrogen potassium exchangers to get rid of excess acid. And your kidneys can also reabsorb bicarbonate ion if your blood's too acidic. That way you can make it more basic. Now, in terms of what a respiratory or volatile acid is, that's going to be carbonic acid. So if y'all remember, we talked about how CO2 and water make H2CO3, or carbonic acid. Now, what's interesting, though, is that this carbonic acid, or H2CO3, can spontaneously dissociate into hydrogen ion and bicarbonate ion. The hydrogen ion is a conjugate acid here, and the bicarbonate ion is a conjugate base. So if you increase CO2 levels in the bloodstream, because you have a lot of water there already, immediately that's going to form H2CO3. So increasing CO2 will, first of all, cause an increase in CO2 in the blood, which makes sense. But that also eventually and pretty rapidly increases the concentrations of hydrogen ions in your bloodstream because of the formation of carbonic acid and the dissociation of that acid. This therefore lowers the pH of your bloodstream, but it also increases the amount of bicarbonate ion you find in your blood too. Remember, bicarbonate is an important buffer. So what's weird here is that although CO2 can lead to the formation of an acid, it also leads to the formation of an important buffer, which helps to stabilize your blood pH. So you want to breathe off or eliminate enough CO2, but not too much. So this question here says, true or false? Serum levels of pH and CO2 are directly proportional. Like, is it true that increasing CO2s would, increasing CO2 concentration would increase pH? And we know that that's false, right? Because an increase in CO2 would actually decrease pH because you're making it more acidic. So what about the metabolic or non-volatile acids? So the metabolic or non-volatile acids, we talked about, things like phosphoric acid, lactic acid. These come from metabolism, and they don't turn into gas, which means they can't be breathed out, right? And so the metabolic or non-volatile acids are actually going to be eliminated by other secretions and excretions of your body, right? Especially excretion into urine. So from metabolism, as you have more and more metabolism, you start raising your hydrogen ion levels. Some of this hydrogen ion can combine with bicarbonate, which can, act as a buffer. But breathing also adjusts carbon dioxide levels, which can bring your pH back to normal. But you can't rely on just breathing to, sort of mediate blood pH, because again, you can't breathe off these metabolic acids. So, although your lungs are a good sort of short-term way to maintain a normal pH, over time you still also have to rely on your kidneys to get rid of these metabolic non-volatile acids that cannot be breathed out. So what's interesting then is that if you have any kind of disruption of your organs, like your lungs, your kidneys, it can lead to some pretty interesting imbalances, like we have metabolic acidosis and alkalosis. Now, if it's metabolic acidosis, we're saying that because of an increase in metabolism, you're seeing increased levels of keto acids or lactic acid, and these come from metabolism directly. That's why we call it metabolic acidosis. And with this, you see a decrease in bicarbonate ion levels, and the reason why you see a decrease in bicarbonate levels is your lungs begin to breathe CO2 out more quickly in order to eliminate that excess hydrogen ion. But the only type of acid it can breathe out is carbonic acid, or CO2 rather, which also would decrease your bicarbonate levels. And so that's an indicator of metabolic acidosis. Now, metabolic alkalosis is the opposite, where you're having excessive either loss of acid or an increase in bicarbonate ion. And so you might get metabolic alkalosis from, let's say, things like excessive vomiting, where if you lose a lot of hydrogen ions because you're basically vomiting out that acidic gastric juice and you're not able to reabsorb those ions back in your body, that in itself can lead to metabolic alkalosis. And then what your respiratory system does to compensate for metabolic alkalosis is that you actually begin to decrease your respiratory rate. That way you actually can increase the acidity of your blood, and by doing so, you also increase bicarbonate ion levels. So you're holding on to CO2 longer, making more carbonic acid, which is increasing bicarbonate levels. So if you have low H plus but high bicarb, that's metabolic alkalosis. And if you have high H plus and low bicarb, that's metabolic acidosis with respect to these types of acids. But then another way to look at this too is with metabolic acidosis, remember low pH, decreased bicarb, heavier breathing decreases PCO2, which is why you see a decrease in bicarb. With metabolic alkalosis, you see a high pH and a higher level of bicarb because lighter breathing increases PCO2, right? And so the breathing amount is the compensatory response to the metabolic problem, right? So if you have a metabolic dysfunction, then your lungs can have a sort of compensation to that problem. So if the problem is that you're having too much metabolic acid, well, you're going to breathe more heavily, right? That's going to decrease your bicarb levels. And if the problem is you have loss of acid or an increase in metabolic bases, then what you're going to see then is that you're actually going to breathe more slowly, which increases your bicarb levels. So in terms of respiration and buffers against blood pH, let's look at an example of a scenario here where a woman has given an acidic IV, and so she began to breathe more heavily as a result of that IV. When her blood was tested, it slightly lowered the pH, which makes sense because it's an acidic IV. She has a lower bicarb, low PCO2, and slightly higher potassium levels. And her urine pH was also slightly lowered. And so this question here says, why did these responses occur? Well, if you gave someone an acidic IV, you're basically delivering excess hydrogen ion into their bloodstream, right? Now, the first line of defense are buffers, but the second line of defense is your respiratory rate. And so you can actually breathe more heavily to get rid of excess CO2 to bring your pH back to a normal level, right? So if it's low, you can bring it back up closer to 7.35. And when you tested her blood after using the IV, we found that the pH was lower, which makes sense because you've actually injected acid into her blood. But her bicarb was low and her CO2 levels were low. Now the reason why the bicarb and CO2 levels would be low here was that actually occurred after the acidic IV, where she had the compensatory hyperventilation, where she's breathing more heavily, so she's breathing out more CO2 and therefore also losing bicarb because you're losing carbonic acid. Now we also find that in her bloodstream, her potassium levels were also slightly elevated. And this is going back to the hydrogen-potassium exchanger that your kidneys can use, where if you have excessive hydrogen ions in your blood, your kidneys can secrete a hydrogen ion but reabsorb a potassium as a result, right? And because you're secreting or excreting hydrogen ions into your urine, it's also going to lower the pH of your urine and make your urine more acidic. So that would explain all these responses. So in terms of respiratory acidosis and alkalosis, we're just talking about the volatile acid, which is basically carbonic acid, right? Because this can dissociate into a gas, which is CO2. So carbon dioxide, which is basically comes from metabolism, but you can breathe it out. That's why we call it a respiratory acid. When you add CO2 and water, they make carbonic acid, and that can dissociate into hydrogen ion and bicarbonate ion. So if we look at the values for respiratory acidosis, you'd expect to find that they'd have high carbonic acid. That's why it's respiratory acidosis, because you're affecting the respiratory acid or CO2, right? So you have higher CO2, higher carbonic acid, low pH because you're making carbonic acid, and higher bicarb. So what can lead to respiratory acidosis would be low respiratory rate. Like if you're breathing abnormally slow because maybe of like head trauma or too much of a depressant like alcohol or benzodiazepines or morphine that actually prevent you from breathing at a normal rhythm, then all of that can lead to respiratory acidosis. Now the opposite of this is respiratory alkalosis, where let's say if you're breathing really heavily, like hyperventilation, well that's going to decrease your CO2 levels in your blood, it's going to decrease carbonic acid, It's going to increase your blood pH, make it more basic, and you're also going to see lower bicarb levels because of the loss of CO2 from your blood. And so respiratory alkalosis could be caused by hyperventilation, which would be opposite of respiratory acidosis, which would be caused by hypoventilation. So there's some things to consider there.